My interest in transcranial magnetic stimulation began in April of 2013 when I had my first session with a 40-year-old male patient whom I shall call James, who had just gone through a terrible winter episode of seasonal affective disorder which had begun during the Christmas holidays. He described being scared, despondent, and close to suicidal. He told me that his psychiatrist was Dr. Michael Reed. James had tried 5 different medications with significant side effects. He told me that Dr. Reed was now recommending a trial of TMS. When I saw James 10 days later for his 3rd psychotherapy session, he had just had his initial TMS treatment the day before and had then only been able to sleep for 2.5 hours. Dr. Reed had concluded that James had a hypomanic reaction to TMS, had given the patient a new diagnosis of bipolar type 2, and had decided to discontinue the TMS treatment. Instead, Dr. Reed told the patient that he should break a Zyprexa tablet into powder and put a small amount on his tongue, and they would very gradually also add Lamictal. I was impressed with Dr. Reed's approach and decided to keep him in mind for future potential TMS referrals. 9 months later, in January of 2014, I had my first session with a 33-year-old patient whom I shall call Linda. As I sat there in my office and listened to her story and her description of her depression and suicidal ideation, I had the sense that she was so depressed, despite being on antidepressant medication, that something else was needed in addition to talk therapy. I feared that she and I could talk for a very long time without making significant progress. 2 weeks later, I decided to refer her to Dr. Reed for consideration for TMS. I sent Dr. Reed the following email. Dr. Reed, I am referring Linda to you for an evaluation. I put her depression symptom inventory in the mail to you, and I want to elaborate here a little more. I've been seeing her for once or twice weekly psychotherapy. She had an initial severe episode of depression 2 years ago with suicidal ideation and was hospitalized at Parthenon for 4 days and says she probably left too soon. Her depression at the time included overwhelming anxiety, and she states that she had not slept at all for 4 months. She says that she's always been very hyper. She was put on Cymbalta at Parthenon, continued on it, and is upset about a 50-pound weight gain, which she attributes to this medication. She also currently takes Ambien for sleep, which she says is now the only thing she looks forward to, as then I can forget and stop thinking. She has a powerful family history of depression, including both of her parents. She says her father, now a recovering alcoholic, suffered from depression his whole life, and he was hospitalized at Parthenon and given ECT 3 years earlier. Her paternal grandfather was also alcoholic and made a suicide attempt with a razor in Linda's presence when she was 11. Linda describes her mother as having been depressed a lot off and on when Linda was a child. Linda's current 2nd episode of major depression appears to have become several months ago in the fall, which also was the approximate time of the 1st episode. She is very frightened of again going through an immobilizing depression, and she lacks hope of getting well. I have referred her to you, Dr. Reed, partly observing the similarity with our mutual patient James' symptomatology. Worse in the fall, winter, with a very significant anxiety component and sleep problems. I'm wondering if there is a bipolar element to Linda's depression as well. I informed her about the magnetic therapy, and she is excited about that possibility. I told her that you might want to try some medication changes before going that route. I look forward to hearing from you about your diagnostic impressions and recommendations. A week later, I received the following email from Dr. Reed. Thanks so much for referring Linda to me. She's a sweet lady who is clearly suffering terribly. I concur that she is an excellent candidate for TMS, which has been scheduled. In the interim, I will be addressing her insomnia and have her increased her Cymbalta to 120 milligrams. In addition, I'm starting her on Vyvanse, which I find can be helpful in cases of refractory depression. We will be doing pertinent lab analysis as well. Clearly, she is benefiting from the psychotherapy work she is doing with you. I appreciate the opportunity to work along with you in providing care to your patients. Linda completed a 6-week course totaling 30 TMS sessions. About a month after finishing TMS, I received the following thank you note from Linda. Dr. Chanin, I just wanted to let you know how much I appreciate everything you've done for me. I have so much gratitude to you for recognizing how much help I needed. Dr. Reed and TMS have truly worked miracles on me. As I continue to grow stronger, I will always remember how kind and helpful you were. 6 months after my initial session with Linda, I met for the first time with another 33-year-old female patient whom I will call Nancy. I listened to her story, including a long struggle with depression, and was also struck with how extremely immobilized she was as far as being productive with her life, despite her high intelligence and advanced degrees. After working with her in psychotherapy for 3 months, I made a referral to Dr. Reed. Here is my email to him. Dr. Reed, I've referred Nancy to you for an evaluation. She is currently on 30 milligrams of Prozac and Xanax PRN. She was first diagnosed with depression in college while on a term abroad in England. She then saw a psychiatrist off and on for 7 years who was very helpful to her, both with her medications and in psychotherapy. She tried going off medication, but that did not go well. I believe that she has struggled with depression ever since the initial episode. She deals with a lot of chronic symptoms and describes an undercurrent of negativity all the time. She has great difficulty being productive. She tends to oversleep and has a hard time being productive until the afternoon. She says, my husband tries to keep me motivated. There's a significant anxiety component as well. She says, I'll panic a couple of times a week. I'll freak out and start crying, and I don't want to be touched. My husband wants to hold and comfort me. I just want to get away. Nancy has a virulent inner critic voice and says that not good is her running narrative as she struggles to work on her dissertation. She describes her father as a lifelong alcoholic and in terms that suggest to me a serious narcissistic personality disorder. He was extremely hard on Nancy. She says nothing impresses him. He became seriously depressed recently when he was forced out of his job. Nancy describes her mother as very insecure. Dr. Reed, I'm thinking that you will probably see Nancy as someone who would benefit from TMS. She is 3 months pregnant, however, so that may have to be deferred. I look forward to hearing your clinical impressions. A week later, I received the following email from Dr. Reed. Thank you for the opportunity to work along with you in providing care to Nancy, a very pleasant 34-year-old pregnant scholar. Currently, she is moderately depressed on generic Prozac 30 milligrams. She describes anergy, apathy, anhedonia, and feelings of inadequacy. Her PHQ-9 score was 12. I've asked her to change back to brand name Prozac and initially to continue her same dose at 30 milligrams. She was to see her OBGYN midwife and ask her to check her vitamin D3 level and MTHFR status if not already done. She may well end up on Nevo DHA, which is essentially the prenatal version of Deplin. We discussed TMS, but have decided to try the branded Prozac first. She is open-minded about TMS if it becomes necessary. Again, thank you for the kind referral. 3 months later, Nancy did begin a 6-week course of daily TMS sessions, which concluded in mid-March 2015. The fact that she was pregnant was not a contraindication to doing TMS. Today, exactly a year later, Nancy's life is remarkably better. She has sustained her recovery from depression and her gains from TMS treatment. She completed her dissertation and graduated with her PhD. She's an involved mother of an active baby boy. She has cut off contact with her toxic parents. She's involved in a national job search, and her overall mood and outlook on life are very much improved. In summary, Linda and Nancy are 2 of the 8 patients I've referred in the past 2 years for TMS to Dr. Reed and to Dr. Scott West in Dr. Reed's office. Dr. West runs the TMS clinic, and he's been particularly helpful with some of my patients who needed financial accommodations to afford TMS. The patients whom I've referred for TMS have struggled with major depression for years or decades. They've been on a variety of antidepressant medications without gaining remission from depression. They are often discouraged and hopeless about their prospects for getting well. Prior to learning about TMS, I was seeing severely depressed patients who were going through electroconvulsive therapy, ECT. As this involves anesthesia, they had to have someone drive them to and from appointments. They could not work while undergoing treatment, and they experienced a lot of memory problems. In my view, TMS has been a great advance over ECT. I also hear from my patients about how responsive and available Dr. Reed is to them. He's accessible to them anytime by email. He generally schedules 2 hours for the initial evaluation, and all follow-up appointments are for 45 minutes, not the 15 or 20 minutes that seem to be standard with most other psychiatrists with whom I've collaborated. Please welcome Dr. Reed to NPI.
Thank you, Phil, and thank you, NPI, for having us both here. Thank you to Dr. West and Nashville TMS for underwriting this event as well. But Dr. Chanin and myself are excited to be here and to share with you what we've seen in our collaboration of treating some extremely depressed people over the past several years. The method that we're really going to be talking about, of course, what makes this different is transcranial magnetic stimulation. So the T is for transcranial. This is a non-invasive technique. We are going through the skull with the magnetic energy. The patient will come in and sit in what looks like a dentist chair. I'll show you in just a minute. And we find the spot in the brain we need to be, which I'll also show you how we do that. And then we relocate it over the dorsolateral backside of the prefrontal lobe. So the part of the brain that's not working right when someone's depressed. And in each session, once we've started, it's a 37-minute period of magnetic stimulation coming in trains or in pulses that are 4 seconds long. So the person's not constantly experiencing it. It's 24 seconds, 26-second rest, and then it repeats itself and goes on for 37 minutes approximately. The person comes in 5 times a week for about 6 weeks until we finish 30 treatments. I'm very thankful to this patient, a volunteer actually. No, this is one of the nurses from Nashville TMS. This is Carrie Ann, in case you recognize her. But she's demonstrating for us what we have a patient do when we do what's called the MT, that's the motor threshold hunt. So I asked them if they've ever played Battleship, because it's sort of like that. we start moving around. So you can see Carrie Ann we will tell the patient to get in the hitchhiker position, which most people know what it is. They raise their hand and extend their thumb because I'm going to move their thumb with the magnet. Their thumb's on the right side of their body or on the left side of their brain. So it's controlling on the opposite side of the body. And just a little bit, it's not extreme movement, but enough to know where we are. Because as you can see, the way the thumb is represented and the face is represented on the surface of the cerebral cortex, it's a lot more than you would guess. I mean, you see how tiny the body is? Not much at all. But the face and the hands are extremely involved on that part of the motor cortex. Why? Because what sets us apart from the rest of the animals is manual dexterity and communication. So that part's developed a lot more. And the thumb's a decent target. I'll settle for the index finger, but if I try to get the thumb, because once I find it, oh, this is what we'd look like. Thank God that the distribution's a little bit distorted, or else that'd be us. So, but once we find the place on the motor cortex, back there in the blue, once we see that, right in there, we move the magnet to there. So the magnet is on an arm. It's a crescent-shaped horseshoe magnet. You can't really see the magnet itself. You just see the crescent. And so the treatment itself is going to occur on the dorsolateral prefrontal cortex. Why? What does that do? We know it's not working in a depressed person, but when it's working, what does it do? Initiates and carries out goal-directed behavior. It's responsible for planning, goal setting, attention, memory, set shifting. So that basically avoidance of ruminations, reward evaluation, getting pleasure from activities. Think about it. If that wasn't working, what would we see? Apathy, anhedonia, the very things that we see so often in depression. The other thing that it does is it's considered the executive functioning center. So I think of that as it's supposed to make the other parts of the brain behave. And if it's not doing its job, we run into problems. Anybody guessing on what that might be? Those little red dots? Exactly, the amygdala. There's really two of them, a right one and a left one. But what I was taught in medical school was the amygdala was the kill center of the brain. And how I explain it to patients is, if I had an electrode and I stuck it into your right amygdala, you would jump off that couch, knock me over in my chair, and beat my brains into the ground. Unless I could get it out and stick it in your left one and stimulate it, and then you'd be in the corner huddled in fear. So it's the fight or flight mechanism. We all have the ability, should we need it, to kill. Before we go further, though, we've got to catch up on our science, sort of get current with what we know science-wise in psychiatry. And it might be surprising. What we know now is depression is inflammation of the limbic system. Most people don't know that. I'm starting to get feedback from patients now where they're saying, I read that. The fact is we all know that. If you said Mediterranean diet helps with depression, why? Inflammation. You start thinking, did you know, as everyone knows, we're now in the dangerous time of the year. It's March, April, May when most people kill themselves. Why is that? I mean, I've never made any sense before. Sure it is. Pollen, inflammation. That's what it happens. So that's a fact. We know that. Depression's inflammation of the limbic system. Now this is the part that a lot of people are not aware of yet, including doctors and psychiatrists. Is depression an autoimmune disorder? Is sometimes that what we're really looking at? Let's look at it. Let's think about it. What do we know about autoimmune disorders? They're all inflammatory based. They all involve chemicals called cytokines. Those are inflammatory chemicals the body makes. One in particular that's notorious is interleukin-6, IL-6. We know fatigue is the hallmark of an autoimmune disorder. Is it related to depression? As far as I'm concerned, depression's been misnamed as a mood disorder. if we should have some category called called energy/motivation disorder and put it under that. That's really the more prominent symptom. Females to male ratio, 3-to-1 in autoimmune, same in depression. Why is that? The Y chromosome offers some sort of autoimmune sparing. We also see that autoimmune disorders cluster together with other autoimmune disorders. Rheumatoid arthritis, 71% chance the person's going to be depressed. And it's not from bone pain. That's what we used to think. Now we have medicines that can treat that. As a rheumatologist said to me, guess what? They're still depressed. The psoriasis, Crohn's disease, narcolepsy, we see that all the time in our patients. Comorbid illnesses, because autoimmune disorders like to hang out with each other. Genetic transmission is important when something's autoimmune. Familiar patterns are the norm. Need I say more about it? It's obvious in depression. Aggressive treatment of the index episode can change the lifelong severity of the illness. They're doing that now often with rheumatoid arthritis. Aggressively treating, I'm thinking, what are they doing? These symptoms just started. They're doing it so the person won't end up with bad RA. Can we do that in psychiatry with depression? Yeah. Research has shown us that for 10 years. Find the index episode, treat it aggressively, that person has a different disorder. Craig Clark, child psychiatrist in our practice, tells me he sees that all the time. He says the people he treats like that, he doesn't see them later in life as much, or he does, different way. But to me, it's the last part that really hits home. Every single condition that's capable of postpartum flaring, every one of them without exception is an autoimmune disorder. Anything medical that's capable of postpartum flaring is by nature autoimmune. Can depression do that? Norbert Glacier back in 2007 told us that postpartum depression was an autoimmune disorder. But most of us don't read autoimmunity reviews and we missed it. So it is one. What does that mean, though? Really, what is autoimmune? It simply means that the body thinks part of us is bad or foreign, and it attacks its own tissue. It turns on itself. To clarify, everything I'll tell you, I'd like to think that's PubMedable. It's all research-based, except for this next part. This is my opinion, but I can't think of a group I'd rather share it with. And I'll explain why. Let's start backwards with rheumatoid. Let's take a step back. Go to rheumatoid arthritis. Let's say I have it. My body might decide that my left elbow is bad, inferior, inadequate, not good enough, fraud, shouldn't be there. It'll start to destroy it. If I don't get on the right medicine, it will destroy my elbow over the decade to come. So, if we think about it, what if the mind turns on itself? What if someone with depression, what if that means their own mind is telling them they are bad, there's something wrong with them? What if that kill center of the brain goes after the patient? What would we see? And, is this something that we haven't been told? Freud told us 99 years ago. Depression was anger turned inwards. He was ahead of his time. What would we see if we saw that? Yeah, but am I going to go stick my head in that noose? No. Let's pretend I'm the depressed person. First, my mind's going to tell me, I don't need to see a psychotherapist. I don't need to be on medicine. I don't need to get treatment. There's nothing wrong with me. I'm just inadequate. I'm not good enough. If I was good enough, I wouldn't have to get treatment. Or I'm just lazy is really what's wrong with me. The reason why nobody can help me or none of the medicines work is because there's nothing really wrong with me. That really, I'm just a total screw up. I just can't do anything right. In fact, I'm making everyone miserable. I'm making my family miserable. Be better if I wasn't here. I'm going to suffer the rest of my life. If I only had the guts to do something about it, well, heck, I wouldn't even do it right if I tried. Last person who told me those two things, unfortunately, ended up like that. So the illness talks the person into believing they are not good enough. Doesn't it? So what I find, that's why I said can't think of a better group to share that thought with, is It's from doing psychotherapy with depressed people that I started to think, oh my God, these are autoimmune disorders, and started looking at it. I started realizing everybody I was treating seemed like they were sabotaging themselves. One thought led to another. Anyway, I will go forward because of time. The great news is this: TMS can help us now. It can correct that hypermetabolic state of the amygdala. What else does it do? It also downregulates a hypermetabolic anterior cingulate gyrus. What's that? It's important. It's like a ram's horn part of the limbic system. Comes around the front of the lobe, front of the brain. It's important in error detection, modulating affect, empathy, vigilance, things like that. Remember, it's hypermetabolic. The boss is asleep, not watching it. The executive functioning center is not doing its job. Do people who are depressed think they've done things wrong more than the average person? Yeah. Do they have trouble controlling their affect? Extremely. Empathy? I know of one person I treat who, when she's depressed, if she's driving down the road and sees someone in a bad situation or misfortune, it'll make her cry. In vigilance, oh my gosh, she can't stop worrying. Worry, 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 worry. In OCD, it's also hypermetabolic. So, a lot of information to dump on you at once. Let's take a break for a second, all right? Let's look at a way, let's use a measuring device and just give a quick quiz, and you're welcome to take it yourself. If the person next to you happens to write down their answer, though, if you look at it, you're HIPAA violators who don't do it unless they give you written permission to do it. But here's the main question would be, over the past 2 weeks, how often have you been bothered by any of the following problems? And the patient is instructed to answer like this. 0 means, that's not a problem. 3 would mean, well, about every single day that's a problem. 1 would mean, sometimes, a couple days past 2 weeks. And 2 would mean, about half the time. So, you can give yourself the quiz. Little interest or pleasure in doing things. Feeling down, depressed, or hopeless. Trouble sleeping or sleeping too much. Feeling tired or having little energy. Poor appetite or overeating. Feeling bad about yourself or that you've let yourself or your family down. Trouble concentrating. Moving or speaking so slowly that other people might have noticed. Or the opposite, being fidgety. Thoughts you'd be better off dead or of hurting yourself. Then I have the person add up their score. So 0 to 5, normal. Most people have some score on something. 6 to 10, mild symptoms of depression. 11 to 15, moderate symptoms of depression. 16 to 20, moderately severe. 20 or above, and that's when you want to be thinking TMS. Even back to 16, I'd say. Definitely be thinking that, and even lower, but still 16 or above for sure. That's because 20 and above is severe. So when you see that person's in trouble. To move forward though, all right, does it work? If it does work, how does it work? In China in 2010, Hugh Ping and associates were using TMS to rehabilitate stroke patients. In the United States, that would be off-label use of it. What they found was it decreased interleukin-6. There it is again, that same cytokine. Thus, it reduces inflammation. It also depolarizes neurons. Long and short of it means it raises neurotransmitter levels back to a healthy normal. But the cool thing is it does something called, it promotes neuroplasticity. What is that? I mean, it increases brain-derived neurotrophic factor, a substance produced in the glial cells of the brain that promote formation of new neural pathways, new dendritic growth and sprouting. So we have this person that we're trying to help in psychotherapy who suddenly has all these new dendrites growing and sprouting and able to do psychotherapy more than any other time in their life. In fact, I'll even say to a person who's depressed now, a person who's undergoing TMS, this would be a really bad time to pick up a new habit if it's a bad habit. Don't do it, because it may just ingrain. It's our job to get inside the head of anyone doing this and to do psychotherapy with them and help them facilitate how those pathways grow, because they're going to be more open to it than ever. Is that all it does? No. There's one more thing, but to look at it first, we've got to think outside the box. We've got to go not this way, but three-dimensionally, because TMS also affects brain waves. If you've had college physics, high school physics maybe, and played with tuning forks, let's say I have a 10 hertz tuning fork, and I give Dr. Chanin a 10 hertz tuning fork, and then he holds his up, and I take mine and smash it against my hand, make it vibrate, and point it at his will start to vibrate too, if it's 10 hertz. I've entrained his tuning fork. So with TMS, we are synchronizing the amplitude and frequency of brainwave activity. We are entraining the person's brainwaves. So think about it. This is what I use most often when I'm treating patients is 10 hertz. The background rhythm of the brain is 10 hertz. So alpha state is 8 to 12. We are taking the alpha state and synchronizing it and getting them going. So what does it do? Which one of those is it? It's every one of them. TMS reduces inflammation by decreasing interleukin 6, raises neurotransmitter levels. The neuroplasticity allows the brain to rewire itself, and for people who get this to have unbelievably, possibly permanent, long-lasting benefit. And then the brain waves are synchronized through entrainment. So it's almost like we fix the car and then we jump start it. To me, this seems almost not possible. I mean, I often will think, it's like a piece of the future has just rolled and landed at my feet. You know, we shouldn't be able to do this, but we are. Does it really work? Finally, let me get to some patients. Mary Lynn was a lady that I've known for a really long time. I've treated for a very long time. And to be honest, she was so negative, such a negative person that he was the type of person you had to sort of brace yourself before you saw. And I even told the TMS nurse, Carrie Ann, I said, with this next person, you know, be ready, just brace yourself, because she's going to be negative. But I said, but if we help her, I said, I will sing the praises from the mountaintops as far as how much this can work. Did it work? Yeah. So let me explain this. What we're looking at on this is, on this scale here is the PHQ score. She started off bad, I think that was a 25, and got as bad as you can get. 27's as bad as you can get, 10 treatments in. So I'm thinking, oh my God. I mean, this lady's working a second job at Home Depot to pay for this. I'm thinking, oh my God, please work. And then look at the end. So before the treatments ended, I distinctly remember the time I walked up to the room and heard laughter from coming inside the treatment room and thought, I've got the wrong room. And then I realized, oh my God, no, it's her. And she soon told me, I don't even understand how I used to think like that. I don't know why I was so negative. Absolutely stunning. In its early years, TMS, Mark George did, 1995 was the first study at the NIMH, 6 patients. Next 10 years, there were some studies put together, big studies. And in 2008, Neuronetics got it approved for treatment of unipolar depression. Those early studies were not honestly that impressive. I'm so glad they got it approved because it allowed for things to come. But if you look back at them or people tell you about them, they really weren't showing what we were to see soon. James, Dr. Chanin's already mentioned him. So, as you saw on that last slide I just said, it was FDA approved to treat unipolar depression. He was the man that had, who had a lot of anxiety, winter worsening, terrible insomnia. At one point before I gave him TMS, thought this guy may have bipolar disorder, and I gave him a medicine for it, and it just drugged him. And so I thought, nah, he doesn't. Yes, he did. So with what we found was on that first, he was the easiest MT I've ever done. It was almost bizarre. Suddenly, right away, his thumb's moving. It usually takes a while to find it. Treatment starts off depressed. Into the 37 minutes, he was not depressed. He was already better, not normal, right? By the end of that day, he was better than that. Before that night was over, he was better than ever. The next morning, he slept a couple hours. I said, okay, we're not doing it anymore. So and we changed the approach. In 2014, gains and all, by then enough studies had come out where they could do a meta-analysis and look. And what overall was found was that if people receiving TMS were 3 times more likely than placebo to get help, but were 5 times more likely than placebo to get actually well. So that was, I think, important to see what we're seeing. There's not many treatments that can get people that well. Does it always work? And if it doesn't, why not? Let me introduce Sally. Sally's a 58-year-old lady, married to an ophthalmologist, apathy, energy, anhedonia, and a lot of hypersomnia. So, so I've told her, we've got to work on this. You can't sleep too much. So surprisingly today, if there's only one thing you take away from this room, as I tell patients, if I was getting ready to drop over dead and there was only one single thing I could say to you, do you know what it would be? And it would be this: do not sleep more than 8 hours in a 24-hour period. I'd even extend it to say, don't even lay flat that long. Don't be supine. If you're not using your muscles, I'd count it. I've seen it happen when people are in recliners, right? It won't work. They won't get better. In fact, nothing will work. You can do any form of psychotherapy you want. You can do any medicine you want. Nothing's going to help that person. There's no medicine to get them better. There's no form of therapy to help them until they stop doing that. And it wasn't until a few months ago that we knew why. And unfortunately, I couldn't locate the study, so you just have to trust me on this one. But what it was that interleukin-6 levels linearly increase the longer the person's. And so that's the explanation. So with Sally, I rode her like a horse and just saying, you can't do that. This will be a waste of your money. Don't do that. It's not going to work if you do that. To the degree that I finally decided I'm driving this poor lady crazy. I'm not going to say it to her anymore. Well, that was a mistake, because here's what happened. She started off doing great, got a lot better, was on her way to getting well, and then unbeknownst to me, until it was over, went back to doing this. Again, self-sabotage, autoimmune disorders, see it all the time. I can't really talk about that last one without at least having a chance to present this one. So Sarah is a lady who was an accountant. She was just not, they were taking advantage of her at work. She worked her to death. And she was just worn out from what they were making her do. Been in a relationship with a guy for a while. It began to feel more like he was her friend, or roommate, than he was her boyfriend. Gone through excessive having plenty of psychotherapy, and just kept getting stuck where she had ruminations about being angry at her family. And as she put it, she had tried every antidepressant that was possible from once she'd reached puberty. So finally, we did TMS. Sarah's the poster child of TMS. We couldn't ask for a better response than this. Tremendous improvement right off the bat, continued through to the end, so complete remission of symptoms. TMS continues to evolve. The Neuronetics got their FDA approval expanded to what it should be. Multiple different medicines have been tried. Deep TMS came along. I won't explain that today. Blue Cross Blue Shield began to cover it. It depends on the coverage part. But what do they request? What does an insurance company want for us to do TMS? The patient has to have failed 4 different trials of antidepressant medicines. 2 of them had to be augmented by a second drug. And I like this part. Finally, insurance is catching on. They also had to have undergone extensive psychotherapy in order to even be considered. Which is important, too, to go back a second, because the cost of it is $400 a session. There's 30 sessions. So it can be, it's expensive. So if insurance is going to cover it, it's very helpful. But I've seen more people do it that didn't have insurance coverage. And as one man told me, it's the best money he'd ever spent in his life. I'll go show you an example of what that looks like. Linda was a 33-year-old teacher. Dr. Chanin had mentioned her earlier in his talk. Much anxiety, worsening in the winter, frequent insomnia, no history of depression before this whole thing started 5 years ago, and then had even been put in the hospital for what she was having. And as Dr. Chanin's words, he said he began to fear that he and Linda could have talked for a very long time without making any significant headway. So he referred her on. I'd seen that she'd been on 5 different antidepressants, including Abilify. That is really what had caused that weight gain, 50-pound weight gain. So we did TMS, worked like a charm. And that's what actually, as she said, TMS saved her life. Finally, a study comes out, 2013, that's called a naturalistic study. What that means is that instead of just when you look at if you look at anything online about TMS, be aware you might be looking at something where they're comparing TMS to simply placebo, right? There's even the people in the room are not allowed to engage with the person getting the treatment because that could constitute psychotherapy. So they are, it's not what the person would receive if they came to get care in a private setting. But even so, in this study, that's not what happened. In this study, they were allowed to do whatever they needed to do, include providing maintenance TMS if more TMS was needed. They were allowed to give the patient medicine if whatever they needed, psychotherapy. And what they found was at a year out, 68% had improved, 45% of the people had complete remission. Remember now, these people are the same ones that had failed 4 trials of antidepressants. These are not people that are typically easy to get well. So in my belief is really treating depression that's refractory, and treating all depression for that matter. It's not one thing. It's not like a medicine, nor is it simply psychotherapy, nor is it any simple one thing. It's a bunch of things. As I tell them, we need to get your ducks in a row. And as psychotherapists, we have to realize we're one of the ducks, right? So we've got to get everything in line. What's that mean? I'll start with, I want to see their lab work. Is their D3 okay? Is their B12 okay? And I can tell you this too. Do they live in Nashville? Their D3 is not okay. We have 220 cloudy days a year. We have pollen most of the time. Pollen and clouds filter out ultraviolet B from the sun. If they're not taking D3, it's not going to be okay. And okay is not 30. If that's normal, right? That's normal range, 30 to 100. Well, 70 is passing grade, but do you want one on a test? No, we want to, higher. So do we need to look at other things? Homocysteine, for example. Do they have a urinary tract infection nobody's picked up on? Do they have, are there hormonal issues we've got to address? And something called MTHFR. It is crucially important. 30% of people walking around have an MTHFR mutation in their DNA. If they walk into my office, they have a 75% chance they're going to have one. What does that mean? It means their body's going to have trouble converting folate into L-methylfolate, which then goes on to form neurotransmitters. Most of these antidepressants we're using are reuptake inhibitors. What's that mean? Recycling blockers. If they don't have enough neurotransmitters to begin with, we're missing out. So we've got to make sure that's okay. I look at their medicines, and as I said many times, psychotherapy's got to be in place, ready to go. They need to be open-minded to it. And in looking all this up, I came upon something. Psychotherapy needs to be in place for the reason I already stated. The person's going to be ripe to change. But there's something else I came upon that I thought I needed to share. And that some of this stuff was cutting edge. This is the bleeding tip, because it's not out yet. It's coming out next month. De Silva and his associates are going to publish next month in the Journal of Psychiatric Research that psychodynamic psychotherapy treated depression by lowering interleukin-6 levels and therefore inflammation. So everybody in this room is actually a neuroimmunologist, whether you knew you were or not. We're all part of the brain team. And so now, what do I see? What goes on? I looked back, divided my patients into different groups for the purpose of this discussion today, and just looked at my most severely depressed people, the ones that had 15 and up that I'd done the treatment on it. And what I saw overall was this: 88% of the people treated got significantly better. Of those, half of them had complete remission of their illness. If we kind of modify the harshness of what we have to use to make it significantly better, just a little bit. If we just say, okay, what if the ones that didn't get all that much better, but they got some better, 40% reduction in symptoms better. 100% of the people did. No one has got nothing out of it. And that's basically what I look at for most people on average. So we've been talking about all these people with refractory depression. Let me give you a break here towards the end. Yes, great. Okay, and tell you about Sam. Sam basically has bipolar disorder. No matter what I treated him with, he would end up having a bad reaction to. So I said, "Here's your chance." We gave him TMS, and he ended up off medicine. 3.5 years later, he's still not having to. So is it safe? Well, let me quickly get to the last patient. What about with pregnancy? We have to go to Turkey to find out any really studies that have been significant. 30 patients they looked at did really well. If we look in the United States, in University of Pennsylvania, they did it on 10 women, but what I really like about this study is that they did fetal monitoring, and they also did contraction monitoring. So did the baby have anything strange happen while the treatment was going on? Did we induce labor? And the answer was no. So the last patient, let's meet Nancy. I think of Nancy as a 33-year-old pregnant scholar because she went to law school, graduated, and decided she wanted to get a PhD in English Lit. And that's what she was doing, therapy with Dr. Chanin, very irritable, undercurrent of negativity all the time. That's what happened when we treated her. Great response. And even better, no postpartum worsening after the delivery. The pregnancy was uneventful. And her son now is doing great, easygoing temperament, normal developmental changes. And as Nancy and her husband like to say, he is their happy little TMS baby.
How do you know that TMS does not, since depression is often hereditary, how do we know that TMS in a pregnant woman is not preventing depression?
That's a great question, and I guess time will tell, but I think that is a wonderful idea, that maybe that really might be what happened. We don't know. So the future's not just coming, it's upon us. Climb aboard. Mental health care is evolving, and TMS is going to be the pivotal point. So at this point, I know we're out of time, but I'll answer any questions that anybody might want to ask me or Dr. Chanin. Yes, sure.
Why is it so expensive?
Each time the treatment's done, a treatment pad is used that costs a great deal of money. So it has to be replaced each time. That's part of the cost. And the machine itself is not inexpensive. So I personally do not own the equipment. I sublease it, but it's expensive. The equipment's expensive. There's a nurse continuously with the patient at all times. You put all those factors together, it just starts to add up.
Does TennCare cover it?
I don't know the answer to that. I don't think so. Medicare does.
Does treatment have to be repeated?
35% of the time, the patient may need some maintenance TMS on down the road. I've had a couple of patients that I did repeat the whole 30 on. Strangely enough, because insurance wouldn't pay for maintenance, I said, they just need a couple. They say, we won't cover that. I said, well, I can do the whole thing again. They said, okay, do that. Yes.
Is it painful? What does it feel like?
Oh, I meant to say that. Thank you for asking that. So the risk, I think I somehow skipped over this. The risk of doing it, there's a 30,000 to 1 chance of a seizure. That's the biggest risk. Beyond that, the actual treatment itself is, the only side effect of it, I should say, is that it is it's called discomfort at the application site. Most people don't perceive it as pain. Some do. It just feels weird. But it,
One of my patients said that it felt to her like having a little woodpecker in her head.
yeah. So but it can be a little more intense than that for some people. But no one ever has said to me, "Stop! I can't do this." Yes.
Back to the finances. If insurance doesn't cover it, can you bill it as an out-of-network?
Yeah, I'm out of network, so sure.
So the $400, because you can meet your deductible pretty quickly at that, and then they'll reimburse that whatever rate is normally reimbursed at?
Yeah, I mean, once out-of-pocket max, you're thinking, is that what you're saying? Yeah, we've seen that happen where somebody hits their max and it's covered by that in that way. Sorry, one second. Yes?
What about using it as a treatment for postpartum depression?
I think that's a great idea. I mean, as far as doing it during pregnancy to prevent it or after it?
It's more like if you actually end up in a postpartum depression. At that point, is it worth doing?
Absolutely. Here's the thing. It will still run the same thing will come back up again in that, is it safe during lactation? Nobody knows. So, I mean, and we won't know forever because you can't really do that study, right? You can just see the outcome over time.
I don't have any concern about the safety for the pregnancy. I think it probably is.
I think it is too, but I think that's a great idea. Yes?
Two quick questions. One, is Blue Cross the only insurance that covers it?
No, there are others. I would say the ones that are notoriously not helpful is Aetna and United Healthcare. But I think there's movement towards more and more paying for it all the time.
And you mentioned the NTHFR analysis.
Yes.
Is there another way to increase that if that comes back and the levels are low for a couple?
Yes. So there's several choices. I usually put the person on Deplin. If their homocysteine level, which is related to all that, is elevated, I think of it as neurotoxic gunk, and it can cause depression in and of itself. I use Inlight. Is there time for any more? Okay. Yes.
If you do TMS on the brain, does it help other autoimmune disorders that the person may have?
That's a great question, and I think so. There's been no studies to do it, but I've done it on a few people where I've made it clear to them before we did it. This just be good luck if this happens. I'm not promising you anything, but I'm hopeful, and it did help them in other areas.
I'm not sure that anger turned inward is all that different than anger turned outwards. Have you tried TMS with people that have huge anger management issues or a history of violence?
No, I personally have not seen that or seen any research on it. But that's a good question. Yes, sir.
Age limitations.
The FDA approval was, I believe, if I'm correct, 20 to 70. I've done it on 19 through 79. The only person I've ever seen who did not get any benefit from it, but it really, I don't think was age related. It was a long, complicated story. Was the 79-year-old? I've also referred mainly the patients now that are older. I'll refer to Dr. West because he does Medicare, and so he's treated some of my older, really older. We did an 84-year-old, and so but FDA approval isn't that. That's because that's what the study was done on. Yes.
It sounds like it's contraindicated for bipolar disorder. What about psychosis?
That's a great question. It is not. I don't consider it contraindicated. It probably may sound like it from what I just showed you. I've treated. I showed you the results of my depressed patient. I haven't had a chance to sit down and analyze, but I've treated dozens of bipolar patients with it. To me, the difference is I just have to have their medicines in place to keep them from getting manic when they're doing it. Oh, I'm sorry. In psychosis, that is a contraindication. It's a little. I think it's slow, and it may take 3 weeks before we really see improvement. And so with psychosis, you don't want to wait that long. And also with they could get really delusional about what's going on, and they may think we're really putting thoughts in their head or something like this. Yeah. Well, thank you very much. I appreciate that.
Thank you so much, Dr. Chanin and Dr. Reed, and thank you everyone for coming. It was great to see all of you and all the new people that are here. Please come back, and we'll see you April 1st for the next luncheon.